Good afternoon again, so you'll have to listen to me again, and I will try to, it's mainly pictures. I will try to take you through the story. You all know last year, 17 years, big General Assembly in September, an important one because the end of the MDGs. This is a view of I'm just going to go very quickly because I want to move into the direction of family planning, contraception and abortion. But as a kind of a context, the Millennium Assembly in 2000, where the MDGs were born. You know them, all of them, 8 MDGs, many of them health related, more than in the SDGs. And in 2010, Secretary General did a kind of assessment. Where are we with the MDGs? Do we progress? And which ones were lagging behind? Number 4, child health, and number 5. Number 5, women's health. Why is that? That it's much more difficult. I mean, all the MDGs are difficult, but number 5 was going slower than the other ones. Why is that? Chandra?
One of the indicators on family planning was only, like you said in your earlier presentation, it was agreed upon late, and there were no quick fixes in terms of the systems approaches to maternal health.
Exactly, and because it has to do, that's my vision, with women's rights, which is more kind of different than drugs and medication and how to improve health systems. Based on that assessment, the Secretary General called upon the world to invest in every woman, every child. So this movement, and I would recommend you to go to the website of the EWEC. EWEC is every woman, every child. It still exists, and why do I say this? I will say this again at the end. The UN is calling upon all constituencies to work together and to invest in every woman, every child. Public, private, governments, NGOs, religious, faith-based, everyone. Also the academics. And who is responding slowly, not engaging the academic society. There are and that's why I'm saying we have to do more. We have to be present. We are the one providing the evidence. So we should really know EWEC and think EWEC. Many initiatives have started under EWEC. This is only a few, too many of them, because they work instead of working together, sometimes not knowing about what the other ones are doing. So all this, as this now given a result, well, in 2015, one can say that the health of women and children are higher on the agenda, more stakeholders, more money, more global initiatives, more innovations, new technology, and an accountability framework. But have we also reached our goals? Not really. We have seen an unprecedented reduction in child and maternal mortality. Not as high as we would like to, and we're hoping, but goals are aspirational. So we know that we can do it. We know what works. Now we should do more. Because, and I always come back with one of my role models, Dr. Mahmoud Fatala, an Egyptian gynecologist, who says women are not dying of diseases we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. And the Lancet, again, did some thinking of what is saving lives. Besides, good antenatal and maternity care, one of the best and the most cost-effective interventions is family planning contraceptives. All literature points in the same direction. So there was a rebirth thinking of family planning. Good publications on maternal deaths averted by contraceptive use in many countries, done by WHO, and there was a call for rebirth of family planning. This is my personal kind of figures. In 35 years, I have conducted more than 18,000 deliveries. I didn't count them all, but what I counted was this. 72 women who died in my hands, and more than half of them because of complications with abortion. young girls in the back streets of Nairobi who go, or everywhere, who go for their abortions on Friday night. And then we admit them in the hospitals on Sunday, or we don't admit them anymore, but very many came too late. One in 3 deaths could be avoided if all women had access, women and girls, to contraceptives. That's why now, after 18 years of horrendous neglect, and why is that? 20 years ago, 25 years ago, there was more family planning in a country like Kenya, where I used to work then, than now. Other priorities like HIV have kind of taken away a lot of attention from family planning. That's one of the reasons why, and I don't have time to go into all the details. But if you look now for a leader, a medical doctor who can lead a family planning unit, you have much more trouble in getting somebody with that profile than an HIV expert. So, in 2012, the world has decided we have to do something, and we bring together all kind of coalition of the willing interested in family planning. Came together in London, and the idea was, the goal was to enable access to contraceptives to another 120 million women and girls, because the estimate is that 225 are short of contraceptives. 225 million. So this is a family planning summit, UN, WHO, UNFPA were there, governments, and of course funding agencies. Most of the money came from the Bill and Melinda Gates Foundation. And the goal was to have 110 fewer unintended pregnancies, saving 50 million abortions, women dying, and fewer babies dying. The unmet need for contraception, 225 million women, and the reasons are many. No choice, no access, fear of side effects, quality of care, gender barriers, and these are the numbers in Africa and Southeast Asia. I'm just going quickly over the numbers, and then some statements that we all agreed in the P 2020. Contraception is not only about mortality, it is about less worry, it is about self-esteem, it is about parental care, employment opportunities. Women who can control and limit their families, they have more access to labor market, health, nutrition, education, fewer orphans, higher productivity, smaller burdens, reduced public expenditure. We have all data and evidence for all of us. Higher savings and investments. Contraception is absolutely a human right, and we should have a free choice. What do we see now? Do we have a free choice of contraceptives in the world? No, why not? Sometimes they are not available, but very often now, in our kind of good intentions trying to roll out implants, we only train healthcare providers in implants. So if you go to many, many clinics, you have the choice between a condom and an implant. And dipper, maybe. But pills and IUDs are neglected. So we should really, from a choice, from a human rights perspective, make sure that reproductive rights are human rights, and family planning contraception is one of them. So, rebirth, it's easier said than done. The FP 2020, we are now 6 years old, 4 years, old, and I said it already. Are we moving forward? There is a tremendous effort and money going into family planning 2020 with some results, but we are going too slowly. Where we are now is here. So that means that we will never reach the reduction of these 225 women in unmet need to half of them unless a miracle happens. And I would recommend you also to talk to Professor Wei Hong, who has just finished a great ICRH program in China, showing that with some interventions, she has really reduced the enormous numbers of repeat abortions by half. But I leave it to her to give you the details. Again, much has been accomplished. 8 more women, million women and girls on family planning, but it's not going fast enough. Now, something about abortion and unsafe abortion. 8% of the maternal deaths are due to unsafe abortion. So 23,000 deaths per year could be avoided, mainly in young girls, if we had access to safe abortion. This is the global picture. 85 million unintended pregnancies, so many million abortions, unsafe abortions, deaths and morbidities. And we know where they happen. This is from WHO data. These are the countries in the world and in Europe where we have highest rates. But almost every one of these deaths and morbidities could be prevented if we have sexuality education, family planning, and safe, legal, induced abortion, and care for complications. So here we have a slide on the proportion of safe versus unsafe, and in the African continent, almost all abortions are unsafe. Annual cost, I'm not going to read it, but you can have my slides. So it's an enormous cost to society if we account the lives lost and the millions needed to treat all these complications. The legal context, I think we all know, and I'm going to, we all know that restrictive abortion laws are not reducing the number of abortions. On the contrary, those countries with good legislation that are allowing access to abortions are the ones, the best in the class. I think the Netherlands, Belgium are the countries where we have the lowest number of abortions per women in reproductive age and per deliveries, because there is access to safe abortion and to contraception. As a matter of time, I'm going to skip some of them. Yeah, another slide showing that even in more restricted countries, we don't have less abortions, but less safe abortions, or more unsafe. And I think you all know this case in Romania, which is really the case study there, is showing us that in the old regime, when abortion was allowed, the number, the complications and mortality was relatively low. Then there was Ceausescu, and the abortion laws have been restricted. You can see here we have the modern contraceptive prevalence rate, we have the maternal mortality going up with the restricted abortions. Further restriction, and then abortion was legalized, and we see a dramatic decrease, an increase of contraception and a decrease of mortality. This is something that it is published, but we should use this kind of example. So what can we do as a research community? What can we do as an advocacy community? Use this evidence at a much higher level, because this shows, not in a small study somewhere, but in a country, what abortion legislation can do. The challenges in young girls are even higher, social, cultural, legal. In many countries now, to protect, like in Kenya, to protect girls, there is, sex is not allowed before the age of 18. So that means contraception, access to abortion and to SRHR is really problematic. Economic barriers, health systems. And then 2 more words on this. In WHO, we did a lot of work on consensus objection as well. And what we see in Europe is that now, in some countries, women have to travel 500 kilometers to find a doctor who is willing to do the abortion. Whereas, like in Italy, 70% of the Italian gynecologists refused to carry out an abortion on moral grounds. But the same doctors, they do the abortion in their private practice. You know, so it is the morality depends on where you are. In WHO, when I was the director, we worked a lot on human rights. We really introduced the human rights, and I'm proud to say that this was the first publication of WHO where human rights was in the title. And we really wanted human rights to be in the DNA of all the work, not only on violence, abortion, family planning, but everything on sexual health and SRHR. We made guidelines in all countries, in all languages, to really highlight the role of the healthcare sector. And it's good that we could do that at HRP, which is a bit special program, because if you go to WHO website and you type A for abortion, you won't find it there. Normally you have a list alphabetically of kind of health topics. Look for the abortion, you won't find it. It is under the P, prevention of unsafe abortion. Because politically it was unacceptable to put abortion guidelines. So we have to call them prevention of unsafe abortion. But anyway, they are there. And we even got an award about the work that Metin and Bella in the first place had done on developing guidelines for healthcare providers on abortion. Post-abortion contraception is also something that is neglected. So the guidelines address this as well. In summary, on abortion, elimination of unsafe abortion requires all this. In countries where it's legal or illegal. And this was discussed also in the new SDGs. We want abortion there. We have abortion in the new global strategy. Remember EWEC, there was a global strategy. Now we have a new global strategy. Every woman, every child, every adolescent, abortion is there. We published all the evidence in the British Medical Journal. We know what needs to be done, but now we have to implement. So what is now to end? The role of the research community. Because here we are a network of researchers. And the question is, what can we contribute? Well, I think our moral duty is, in the first place, to conduct good quality research, right? We all agree on that. Then when we have the research, we publish or perish. You know, as researchers, we make our careers and, we develop in publications. Great. But is that the end? One could say yes, because that's a task of research. Or one could do an extra mile and say we have to publish not only in the scientific literature, but also make sure that our data that we know, that they are translated, disseminated, and that they go to the other levels, the NGOs, the policymakers, the governments, and so on, so that we really play a role, that we have an impact, that our work has an impact. We have to do work also on methods, definitely. And this is my last slide. I don't know why it's there, but when we had a course on new innovative contraceptive methods. And we were driving by a little village in Africa where I took this picture. Probably they don't have really high-tech modern contraceptives, and I don't know why this is there. But dissemination is very important, and we have to do that wherever we can. Here we see it, the work that we did already with Neil and EPF, with IPU, to put this high on the political agenda. Researchers should be there. Look in your countries, in your parliaments, look for your advocates. It might be difficult to find them, but you will find them and talk to them and make sure that they know your agenda. So that gradually, it's a lot of work, and you have to be persistent, but that's how you can get your topics higher on the agenda. And we need partnerships. This is public-private partnership, and now we do in Kenya. Look at the private sector. Philips, MSD, Safaricom, from a university and an NGO, we are not used to work with private sector. It's even kind of, we don't know, the pharmaceutical industry, we cannot talk to them. They only want to make money, and so there is kind of a big barrier. But we have to work with them. And once you can form these partnerships in Kenya, we are now very successful public-private partnership working towards reducing maternal mortality in the hardest hit parts of the country and also addressing family planning. These are parliamentarians. We also work with the African First Ladies. If you can have the First Ladies sharing your agenda, they are very powerful. You know, one of them said when the First Lady talks, everyone walks. Well, I must say it's true because they come with their communities, their ministers, parliamentarians, their scientists, and if they talk about these issues, it comes out. And again, my last slide, go to the Every Woman, Every Child website and make sure that we as academics do better. We are hardly represented in that community and we should have a much louder voice. Thank you.